So our next speaker here in the flesh is Dr. Kevin Kalinsky from the Winship Cancer Institute at Emory, and he will be reporting on the updated results from a phase 3 randomized clinical trial in participants with 1 to 3 positive lymph nodes, hormone receptor positive and HER2 negative breast cancer with a recurrence score less than or equal to 25, randomized endocrine therapy plus or minus chemotherapy, the RxPONDER trial.
Dr. Gradishar, Dr. DeMichelle, good morning, everybody. On behalf of my co-investigators, we'd like to thank the organizing committee for the opportunity to present updates from the RxPONDER trial. My disclosures. In patients with hormone receptor positive and HER2 negative breast cancer and 1 to 3 nodes involved, the clinical utility of the 21-gene Oncotype DX recurrence score is now established. In RxPONDER, chemotherapy benefit differed by menopausal status in a pre-specified analysis for participants with a recurrence score of 25 or less, in that postmenopausal women did not benefit from chemotherapy for the primary outcome of invasive disease-free survival or for distant relapse-free survival. However, premenopausal women benefited from chemo. Today, we report updates in IDFS and DRFS, as well as conducted new analyses for distant recurrence-free interval, as well as exploratory post-hoc analyses in the premenopausal subgroup. To review, RxPONDER was designed to randomize 5,000 participants with hormone receptor positive HER2 negative breast cancer with 1 to 3 nodes involved and a recurrence score of 0 to 25 to chemotherapy followed by endocrine therapy versus endocrine therapy alone. For women with recurrence score greater than 25, they were off study and recommended to receive chemotherapy followed by endocrine therapy. At the symposium last year, we reported the initial data from RxPONDER. Subsequent to that analysis, with a median follow-up of 5.3 years, we updated these data, and these data were published in the New England Journal of Medicine online last week. Today, we present further updates with 553 IDFS events and a median follow-up of 6.1 years in the ITT population. In this table, you can see IDFS and DRFS per STEEP criteria 2.0. As opposed to DRFS, DRFI excludes death from non-breast cancer or unknown cause and only includes distant recurrence or death from breast cancer. This is a clinically important outcome given its relevance to long-term breast cancer-related survival. Consistent with the data reported online last week, postmenopausal women continue to not benefit from chemotherapy in this updated analysis for IDFS on the left or for DRFS on the right. However, premenopausal women continue to benefit from chemotherapy in this updated analysis, with a 5-year IDFS absolute chemotherapy benefit of 4.9% on the left and a 5-year DRFS absolute chemotherapy benefit of 2.5% on the right. These graphs are showing distant recurrence-free interval cumulative incidence, the most narrow of these outcomes. For postmenopausal women on the left, there was no chemotherapy benefit for DRFI. However, for premenopausal women, there was a 5-year DRFI absolute chemotherapy benefit of 2.4%. Recurrence score was a stratification factor. In those with recurrence score 0 to 13, this rate was 2.3%, and for those with recurrence score 14 to 25, it was 2.8%. We then performed exploratory post-hoc analyses in premenopausal women given the number of questions that have arisen since we presented these data. We looked at IDFS between treatment arms in participants with micrometastasis only. In 2014, the protocol was amended to exclude enrollment if patients had micrometastasis only, after approximately 50% of the overall population had been randomized. We also performed a 2-year landmarked IDFS analysis between the premenopausal women who underwent ovarian function suppression or not in the endocrine therapy alone arm, as well as a 2-year landmarked IDFS analysis between the premenopausal women who were still having regular periods or not in both treatment arms. These data should be interpreted with caution, given that confounding factors can change over time. Since the last analysis, we reviewed pathology reports on all premenopausal women prior to the 2014 amendment. 206, or 27.9% of the eligible premenopausal women prior to the amendment had micrometastasis only. This subgroup is demonstrated on the left, where you can see a 5-year IDFS absolute chemotherapy benefit of 7.3% with an adjusted hazard ratio of 0.44, but with a wide confidence interval. Please note the limited number of IDFS events in this small patient subgroup. On the right are patients with macrometastasis before and after the amendment. And you can see that there's a 5-year IDFS absolute chemotherapy benefit in the premenopausal participants with macrometastasis of 4.8% with an adjusted hazard ratio of 0.64 and a more narrow confidence interval. We then looked at the effect of ovarian function suppression in the premenopausal subgroup. This graph is showing the rate of ovarian function suppression in premenopausal participants in both treatment arms over time. On the case report forms, the sites reported at fixed time points if the premenopausal women were undergoing ovarian function suppression during the previous time interval. As you can see, as highlighted in red, 16% of premenopausal women in the endocrine therapy alone arm underwent ovarian function suppression in the first 6 months, as compared to just 3% in the first 6 months in those assigned to chemotherapy followed by endocrine therapy. And you can see over time that the OFS rate remained low and consistent in both arms. These are data from the endocrine therapy alone arm. Premenopausal women were categorized as OFS recipients if they underwent medical suppression for at least 2 6-month time intervals or underwent a bilateral oophorectomy in the first 24 months. You can see in red that 17.2% of premenopausal women in the endocrine therapy alone arm underwent ovarian function suppression in the first 24 months. And when performing a landmark 2-year analysis, there was no IDFS difference in the premenopausal women who underwent ovarian function suppression or not in the first 24 months when assigned to endocrine therapy, when adjusting for recurrence score, recognizing that this is a small patient subgroup in an exploratory analysis. And then we looked at the effect of premenopausal women continuing to have regular menstrual periods or not. This graph is showing the rate of premenopausal participants having regular menstrual periods in both treatment arms over time. Similar to ovarian function suppression, the sites reported at fixed time points that premenopausal women were having regular menstrual periods during the previous time interval. As highlighted in red, 50% of women assigned to endocrine therapy alone were still having regular periods in the first 6 months, compared to approximately 25% of premenopausal women in the first 6 months to those assigned to chemotherapy followed by endocrine therapy. You can see that the rate of having regular periods decreased in both arms over time and came closer together. And these are data from both treatment arms. Premenopausal women were categorized as not having regular periods if this was reported in at least 2 6-month time intervals in the first 24 months. On the left are patients in the endocrine therapy alone arm. And you can see in blue that 58.9% of premenopausal women in this arm were no longer having periods within the first 24 months. When performing a landmark 2-year analysis, there was a numeric improvement in IDFS in the premenopausal women no longer having regular periods in the first 24 months compared to those who were still having regular periods, with an adjusted hazard ratio of 1.48 and a wide confidence interval. On the right, the effect is the same with a similar adjusted hazard ratio and wide confidence interval in those assigned to chemotherapy followed by endocrine therapy, recognizing that the rate of no longer having periods was higher in this arm. Both of these analyses were adjusted for age and recurrence score. So in conclusion, in an updated analysis, we report with longer follow-up that postmenopausal women with recurrence score 0 to 25 continue to not benefit from adjuvant chemotherapy. However, premenopausal women with recurrence score 0 to 25 do, with a 44 to 46% decrease in IDFS, DRFS, and DRFI events. We performed exploratory analyses in the premenopausal subgroup, recognizing that these were small subgroups. It does appear that premenopausal women with micrometastasis only benefit from chemotherapy, though there were a limited number of events and there was a wide confidence interval. The majority of premenopausal women stopped having regular periods in the first 24 months, and these women had a numerically improved IDFS. RxPONDER was not powered for subgroup differences. An interpretation of these data can be challenging in the premenopausal subgroup, given that confounding factors can change over time. It remains unclear if ovarian function suppression can replace chemotherapy in premenopausal women with hormone receptor-positive, HER2-negative, node-positive breast cancer. And we conclude that a future randomized trial should be considered to address this important clinical question in a genomically defined population. We'd like to thank the participants and their support system. We'd like to thank the study sponsor, the National Cancer Institute, as well as the funding mechanisms without whom this research could not have been completed. Thank you.
Thank you very much. We have time for just a couple of questions. The first really focuses on, although there are caveats and subgroups we don't have sufficient numbers on to make blanket statements, it would suggest that in most premenopausal women, they still need chemotherapy. So how do you square that data with the mammoprint data, where there may be some, based on that platform, that don't need chemotherapy?
Yeah, so, in the MIND-ACT study, for those patients who were high clinical risk and low genomic risk, there was also this demonstration in terms of 8 years of follow-up that for those women who were younger, that there was a distant metastasis-free survival benefit of about 5%.
Okay. We have a question at the mic.
Hi, I'm Sojin Tan from Mississippi. Congratulations for your New England Journal publication. Question is regarding the incorporation of clinical pathological features. With TAILORx, we now have the RxClean. And I wonder if you plan to do the same for our RxPONDER trial.
Yeah, thank you. Thank you for that question. I think it's a very important question, and those analyses are planned. And I think that what those data showed from TAILORx is that it's not just the recurrence score, it's also these clinical and pathologic features that really help us individualize the conversation when we're seeing patients in clinic.
Second question is regarding the premenopausal women who have 1 to 3 nodes. In your study, you showed that even if they have a no RS score, they still may benefit from the chemotherapy. So on the logistic side, if they have a young premenopausal woman with 1 to 3 nodes, do I need to bother to order the test?
Right, so there still may be some utility for checking a recurrence score in patients who are premenopausal, just given that it can offer some prognostic information. And what we've presented is that while across the continuum from recurrence score 0 to 25, that there's no difference in terms of the relative benefit, those patients who still have a higher recurrence score within 0 to 25 are at higher risk. And their absolute chemotherapy benefit may be numerically higher as well. So it may offer some prognostic information.
this may be a function of numbers, but why do you think the impact was greater in N1 Mike than macromets?
Yeah, I mean, I think that it really may be a function of numbers. You know, there were 206 patients. There were 22 invasive disease-free survival events. You know, and I think that, you know, just along with the caveat of the last question, when having that discussion with a patient, it really is important to consider all the clinical and pathologic information.
And do you have any sense of whether there's a distinction in results based on ductal versus lobular?
So in the paper, in the supplement, about 13% of patients had lobular disease, and we broke this out by menopausal status. And you can see with that forest plot that for the patients with invasive lobular cancer in the premenopausal group, that it does cross one, but there's quite a wide confidence interval just given the limited number of patients.
Okay. I think we're going to move on. Thank you very much.